Thank you very much, Stephen, and thank you to Christina and Doug and to all the people who make this possible, and also to Council. And thank you for coming. So that's a much better Australian accent than the very clumsy attempt that this newbie Australian just did. But I'm not going to reciprocate and attempt a Canadian accent. So you'll just have to make do with this. So I'm going to talk about this topic. Now, at this stage in a conference, I sometimes get a bit worried because I can't remember who gave that title, It's Life. I can't remember whether it was my idea or Christina's idea. So if this goes well, it was my idea. No. I guess what I'm going to do is draw on a whole lot of stuff that I've been doing, not just for ISQua, the International Society for Quality, in my role as president-elect, incoming president, but also as a researcher of a large research group in Sydney, Australia. Now, I've got some questions for you. Who is a patient partner? Thank you. Now, I'm a researcher, so I'm often looking for patterns in the data, and the patient partners seem to be over here, but not over here. Is that right? I'm getting imbalanced here. Okay, thank you. Who is a policymaker? Those are the ones, usually they're a bit reluctant to put their hands up because they think somebody like me is going to, criticize them, but I'm not. Well, a little bit. Who is a manager? Now, I know everybody's in the Matrix movie, aren't they? We've all got multiple roles, but for whom is their major job to manage part of the health system? Who's a manager? Okay, thank you. Who's a clinician on the front lines of care? And who's a doctor? Who's a nurse? Who's an allied health professional, a sort of, yeah? Who's a researcher most of the time? Only me. A couple of people over here. Okay, fantastic, thank you. And who's not from BC? Welcome. If I can come all this way and be the person to welcome you. Okay, that's very good. So what we've got here essentially is a cross-section of the health system. We're sort of representative of out there in the province. And that's very useful because I've got some questions for you later. Have I missed any groups? Educators? Okay. Thank you. Okay. Quality improvement staff? Yes. Who's a quality improvement person? Well, that's everybody, isn't it? You've got to be careful. Listen to the question. That's everybody, all of us. Okay, let me talk about this. First, just a bit about ISQua. My disclosures are I don't have anything other than lots and lots of investigator-funded projects. My institute has about 170 people, about 70 projects, a whole bunch of PhD and Masters by Research students, all of whom are doing work on which I draw. So I don't have any disclosures of secret shares in some business or something like that. So first about ISQua. ISQua is the International Society for Quality. Who has been to an ISQua conference? Not enough people is the answer. So ISQua is kind of like BC, here we go, BC Patient Safety and Quality Council on steroids. Okay, it's kind of the international version of all the good stuff that goes on here. There's 160 countries go, and its mission is to be a global leader of transformation in healthcare quality and safety, in the same way that you are trying to be the leader of and a catalyst for improvement in the province and in your province if you're from elsewhere in Canada. So Simon Donoghue is here. Where are you, Simon? Simon's here representing Esquire. He's not in the room. You'll see him. He's got a display outside. So Esquire has a number of things. It has a fellowship program. If you do the fellowship program, you can be a FISQua, a fellow of Esquire, to go with all the other titles and initials that you have after your name. And that has lots of participants across the world all studying formally with Esquire quality improvement and patient safety. It also has a number of specialist certificates in education. The conferences are always in interesting places. This year, it's Cape Town, South Africa. Can I let you into a secret? If I can have an intimate conversation in secret with 1,000 people. After Cape Town this year, next year, it's going to be in Florence, in Italy. Do I have your attention? The year after, now this is really a huddle, it's going to be in Brisbane, Australia. I know that's a bit of a come down from Florence, Italy, but you know. So why get involved? It has a scientific program just like this conference, and there's lots of activities, and it's a chance to network with people in other countries, including low and middle income countries who have kind of similar problems to the challenges you have here, but they're also a bit different as well, especially around lack of resources and lack of technology. Esquire also accredits the accreditors, and it accredits organisations who accredit others in their countries. It accredits standards, healthcare standards, and it accredits surveyor training programs. And that's where currently it is accrediting accreditors around the world. And the president of Esquire at the moment, remember, I'm president-elect, the next president. The president at the moment is correct. Wendy Nicklin? I know you're not her. I'm on the phone and talking to Wendy every day. Yes. Wendy Nicklin, a Canadian. So we have a Canadian currently, president of Esquire, an Australian next, and who knows after that? Well, who cares after that? You realise right here where I'm standing is the second best country in the world. You realise that, don't you? Okay, that's the advertising. A little bit about my research institute, only because if your work maps to the sort of research we do, we're a big powerhouse group that publishes about 3 or 4 books and maybe 300 papers a year on health systems improvement, all the sort of things you're interested in. So why I say this is, if you want me to connect you with some people who are doing research in Australia, I'm happy to do that. I'm happy to be your triage, your agent. So our mission is to do health systems improvement work by doing the research end of this, not the actual practice that you do when you're trying to improve your health system. And there's 3 of us. As you can see, all Australians are extremely dashing. There's 3 of us. I run the institute and also a centre that's interested in change and improvement. Enrico Coira is a doctor who became a health informatician. You may have seen his work sometimes, if he's got an unforgettable name, I guess, in health informatics. And Joanna Westbrook is an epidemiologist who evaluates IT systems and is interested in safe systems of work. So enough about that. If you want to talk to me or talk to those people via me, I'm happy to put you in touch. So let's get on with the actual talk that you've invited me here for, and thank you very much for the invitation. So let's think about healthcare improvement, because I think that's, if I was to put a blanket over all of us and say, what are we all joined at the hip about, it would be healthcare improvement. We're very keen, aren't we? We're passionate to improve the systems of care for our patients, correct? So maybe that's just a little catch cry for us, a mission statement for us collectively at this conference. Would you agree with that, Doug and Christine? So, Christina and Doug, I am delivering to my sponsors already. I should stop now. Quit while you're ahead. So let's think about healthcare improvement, how we do it, and how we might do it. So, let me ask you a question. By the way, did I tell you this wasn't a keynote really? It was interactive. Did I tell you that? Did you guess that already? What will you do to change this and improve the system? And it's that. It doesn't matter if you can't see the details. So if I present you with that, what are you going to do to change it and improve it? Change the font? It's deliberate. Yes, thank you. Thank you very much. It's deliberate because you're not meant to see the details. They're irrelevant to the question. What are you going to do to change that? Turn it upside down. Are you a patient partner or a frontline clinician? Yes, what? You do see that, don't you? People invert the pyramid and say, we are all in service of the people who are delivering care on the front lines, because they should be at the top of the page. You know the answer to this question. If you're presented with that, there's a huge temptation swelling up in your breast to reorganize it, to streamline it. Is there not? And maybe to issue KPIs to people and to hold people accountable. Is that correct? The problem with that, and I agree with you, the problem with that is it's not a very good representation of the health system, because that's what the health system's like. Now that's interesting, isn't it? So if that's your representation of the health system, you are drawn to doing some things like restructuring, reorganizing and streamlining. But if healthcare is better represented by the right-hand picture, then that's a different order of things if you want to improve care on the front lines. By the way, that representation, that swirly diagram, that systems dynamics map, isn't a map of the whole health system. It's just an emergency department. I haven't got a big enough slide to represent the whole healthcare system. So it is a complex system that doesn't necessarily respond to linear solutions that are overly simplistic. Now, when I give talks like this, well, this was purpose designed for you, of course, but when I give talks, I'm always careful not to tread on the toes of the people who are in charge of the system that I'm giving a talk in their system. But it may be that you are going through some restructuring and reorganizing and changing the KPIs, etc., at the moment. I just want to say, I'm an academic, I'm a researcher, I'm completely apolitical. So when do health systems change? You could legitimately ask me if I've now dichotomized the idea of a complex adaptive system and a more linear organizational chart type system. Well, here's some of the way. By the way, I'm drawing on a paper I wrote in the BMJ last year, changing how we think about healthcare improvement for the purpose of this initial set of slides. So when do health systems change? Well, they change when they're stimulated by some sort of medical progress. For example, a new test comes along, or genomics or something like that. When there's incontrovertible evidence that something benefits the population, such as immunizing infants. And I know that's a bad example if the anti-vaxxers are out and about, but with the deepest respect to anti-vaxxers, I disagree violently with your position. Healthcare systems also change when new models of care emerge. And the best example in the last 25 years has been right across medicine. There's been a shift to day-only surgery and treating people outside of hospital, in rooms, and even home care, which is more recent. And then the other way they change is because clinical practices alter, because professional acceptance, clinicians, doctors, nurses, allied health professionals, largely physicians though, accept a new way of doing things, and it radiates across medicine across the world. When do systems reject change? When do they not change? Because there's an inertia about health systems as well as a capacity to change. Healthcare is a complex adaptive system, but it also displays lots of characteristics of inertia. and rejection of change, as you know when you try and change things, when the primary or sole strategy is top-down, because the front line doesn't really necessarily accept top-down change. It doesn't really necessarily accept organizational structure type change through the organization chart. When the change is not supported by parties with power to resist or reject, read physicians often. All the nurses just laughed. When the initiative encounters entrenched bureaucracy. Now, let me just tell you a story. In my home state of New South Wales, who's been to Australia? Hands down. Who wants to go to Australia? Hey, that's the whole room. In my home state, there are 2,000 policies in operation in the public health system. I put it to you that that's about 1,900 policies too many. Nobody knows all those policies on the front line of care. Sorry, I interrupted you clapping me. Keep going. Nobody on the front lines of care, and certainly no patients or patients groups know anything like that number of policies. So the question you've got to ask is, why are there that many policies? I leave that hanging for a while. Did you notice I counted to 5 in my head and then filled the gap? I'll leave you with that for a second and I'll come back to it. When more and more policies and procedures are issued on top of a multiplicity of existing policies and procedures, the health system can reject that change. Mainly because it doesn't have a clue about that new policy. Also, if I'm telling a story about my home state, I think the policy on conduct, on behavior, how you should behave, is 50 pages. I don't know a clinical professional who doesn't actually know how to behave. And I don't think any one of them, of the 110,000 people who work in New South Wales, has ever read those 50 pages. I'm going to come back to that. It's an interesting paradigm. And then systems can reject change when attempts to alter deep-seated politics and cultures are superficial rather than thoroughgoing. So there in 2 slides is the entire paper I wrote in the BMJ, snapshotting when can systems change and when can systems not change. And largely, the forces for change are bottom-up or middle-out, not necessarily top-down. Okay? Is it like that in BC? You don't have to answer that, especially if you're sitting next to your boss. So to change a system, in summary for this first bit of what I want to say, and I want to set up a couple of other arguments by doing this initial bit. To change a system, we need to look at both the hardware of the system and the software of the system. The hardware is about restructuring, capital investments, financial models, targets, KPIs. And the software is enhancing organizational and workplace cultures, for want of a better term. And implementation and science and improvement over time, putting the system on an improvement gradient. Now, just let me ask you a question about culture. So that's one of the most, 25 years ago, when I was a less senior researcher, a younger person, we hardly used the word culture. 35 years ago in healthcare, they would have thought culture meant high culture, cucumber sandwiches with the Queen, or something like that. Now we use the word culture, it's an interesting anthropological metaphor, culture, for behavior inside the health system, collective behavior. So who thinks, and we're going to vote on this, who thinks that if you have a good culture, one that's productive, trustful, interactive, versus if you have a bad culture, one that's toxic and politicized, and people kick each other in the head or distrust each other, who thinks if you have a good culture in the way I've described it, you will get better organizational and patient outcomes? Vote. Almost all of us. Almost all of us. Now, here's the real kicker question. Do you know that, or do you just believe that? Did you answer that question in an evidence-based way, or did you just hope that you deliver better outcomes if you have a better culture? You were hoping, weren't you? Well, let me make you my gift to you this morning. Let me make you more evidence-based. I've done a systematic review. Shame on you that you haven't read this systematic review. Looking at all the studies in PubMed, there's about 38 million papers in PubMed. There was 62 studies we found, looking at all the studies where they'd measured culture in some form or another, and they tried to relate that, whether the good culture was associated or the poor culture was associated with organizational outcomes and patient outcomes. What did that find? It found in the direction that you voted. Aren't you pleased about that? So you voted hoping that a good culture meant that you deliver better outcomes, organizational and patient outcomes. And that study, that systematic review published in BMJ Open the year before last, at the end of 2017, showed that that was the case. So all of the work you might be doing to try and improve the culture, to make it less toxic, more productive, more trustful, more interactive, more collegial, is good work if you can make the change. But the $64 million question is, can you change the culture so that the new behaviors, the new cultural features stick, and the place is more trustful, interactive, collegial, etc. So that's the kicker question. Okay, so much for the beginning. I have plenty of time, so we're going to have time for questions at the end, because I've got till 9:40 this evening, isn't that correct? You know, get a professor on stage, give him some slides and an audience. Who's stopping anybody? So let me flip over to the next part of the talk, which is to look at complexity science, to look at that second diagram, not the organizational structure. Lots of people are doing KPIs and restructuring and streamlining and changing the boxes on the organization chart. Lots of people are doing that right across the world. I want to look at something that's harder, which is if you've got a complex adaptive system, how do you work on that to improve it? Essentially, it's working on the culture, isn't it? It's working on the culture. Okay, so let's have a look at complexity science. So there are lots of models. Here's one. It says the world is full of things that are simple, easy to understand. One thing leads to another. Complicated, that's getting somebody, an astronaut, to Mars. It's very complicated, lots of moving parts, but it's actually predictable. You know when you'll reach Mars. You can predict that before you press the button for the spaceship to go there. And complex, and that's really the health system. That's a whole lot, and I'm going to define these shortly. And then chaotic, when really you can't really predict. And that's, you know, often the metaphor is the weather. You can predict a couple of days within some degrees of freedom, but really it's very hard to really nail down something as chaotic as the weather, especially, well, no, I was going to say especially with global warming, but of course there's no such thing according to some groups. So in healthcare terms, simple is maybe a checklist. Now, that masks complexity, I agree, but it's kind of like codifying something into a doable set of actions. Complicated is maybe a solo clinician treating individual patients on the front lines of care. Complex is when there's lots more interaction, perhaps around patients, and then chaotic is when the wheels fall off and you really don't know what's going to happen next. So those are the examples from healthcare. And so we thought about this for a long time and thought, you know, the prevailing metaphor, the prevailing mechanism in healthcare in many people's heads is often that one, but really the health system's like that, so we better understand the second one more than we do today. So that's a whole branch. I've got a whole team, half a dozen people, funded by the National Health and Medical Research Council, our equivalent to your CIHR, I guess, looking at complexity science applied to healthcare. So we published a white paper. This is another gift, a freebie for you. It's downloadable from our website. And if you haven't seen it, it encapsulates in about 70 pages what we think about how complexity science can help or illuminate some of the problems people are working on when they work on health systems improvement type problems. Okay, it's a freebie. So what is complexity? Well, it's about the characteristics of a system, and I've encapsulated it in 14 points. And by the way, I'm making these slides available, so if you want a copy, by all means, they're available to you, okay? So it's kind of like got agents. That can be humans, but also agents can be artifacts, things they use, and they interact, and they're relatively self-organized. I mean, if you think of a clinical team on the front lines of care, they're relatively self-organized. They're not waiting for the next policy to drop into their lap or on their computer before they do something. It's collective and it's networked. That is, the lines are connected to each other. Sometimes they're broken lines, but the people are connected to each other, either loosely coupled or tightly coupled. They have rules, and these aren't necessarily the rules in complex adaptive systems. They aren't necessarily the rules that are prescribed to them in guidelines or policies or standard operating procedures. They form their own rules that enable them to mediate their own behaviors and activities and clinical practices. There's something called emergence, which is just a posh academic way of saying stuff happens that you didn't think was going to happen. And if I take you through a shift of your own, when you go on a shift, whatever job you do, there will be stuff happens during the shift that you didn't anticipate. And that's emergence. Stuff is emerging all the time. Stuff is coming at you that you didn't anticipate. There's uncertainty, because in a complex adaptive system, you don't know everything. You don't know how things will interact during the course, say, of even just a shift. It's adaptive and dynamical, means it changes across time. It's rather bottom-up as much as it's top-down, a complex adaptive system. It's transitional, and what that means is every now and again, you can go through a major transition to something else, a new phase of your existence. And that's what people try to do, by the way, when they restructure. They're trying to induce, in the complex adaptive system, a change. However, they often don't achieve that. All they do is actually move the boxes on the chart into a different configuration. By the way, did someone say they were researchers, writing papers in the literature and that sort of stuff? Yeah, where are you? I once wrote a paper in the Journal of the Royal Society of Medicine likening restructuring to sex. It opens with the paragraph, "Some people like watching. Others find it painful. Still others have to clean up the mess afterwards." You like the first two jokes, but not the third one. That's interesting. We're finding out about each other as we do this. The point was that there's a lot of people who are watching restructuring. There's a lot of people who are going through the pain of it, but it often doesn't touch the front lines of care and change the culture, which is what might be needed. So it might be a mismatch of paradigms when we restructure. I'll leave that with you. I'm coming back to it. Also, complex adaptive systems are governed by feedback. That is, they react in response to data and events outside of the complex adaptive system and within. Now, a word for those people who like data in its formal sense, in charts or computers or big data. Most of the actual data that's used isn't of the formal kind. It's the informal, tacit data that you get when you just work with other people in your group. So we often forget that when we're talking about data. The most crucial data is, for example, not the formal meeting that you go to where you pore over all these histograms, but the informal meeting when you're walking down the corridor and somebody bumps into you and tells you something, and you go, aha, that's really changed what I was thinking today. So we often talk about data and feedback in a system, but really it's the informal stuff that's as important as the formal stuff. And I don't need to be an expert in complexity science to tell you that. I'm describing your existence, am I not? And it's path dependent. A complex adaptive system is path dependent, which is another posh way of saying, another academic way of saying, history matters. Depending on where you came from, and when your complex adaptive system, if it's a hospital, say, first formed, that is in the culture and remains in the trajectory just about forever. where you came from and what's in the culture in the initial stages stays with you and reverberates across time for a long time. So that's the properties of complexity applied to healthcare. So let me give you an example. Let's look at obesity. That's a linear problem, isn't it? This is the solution to obesity. Fewer calories and more exercise, and you're going to look like this. Correct? Wrong. Wrong. Because if it was that simple, we'd all look like that. If it was a linear problem, we'd just do the linear thing. That's actually the map of obesity by Butland and colleagues. And I know you can say the font's too small. Did you notice how good a memory I've got? Even though there's 1,000 people in the room, I remember what you said. That's a map of obesity from Butland. And it was meant to describe how obesity works. And it's not meant for you to see from there the words and the concepts. But obesity is determined by individual metabolism, individual psychology, group psychology, food production, physiology, the availability of different food groups. We heard a great talk last night on the availability of organic foods, physical activity environment, the availability of open spaces. There's a lot of things determine obesity. So it looks like a linear problem, but is actually a complex adaptive system problem. Another example, the province's health system. I just took this from the web. The best description of the BC health system I could find is this: a loose network of multiple systems. So if it's a loose network of multiple systems, that immediately says, well, you've got multiple complex adaptive systems. Where are the connecting agents? They would be very important for any system that's like that. We're going to have a bit of a discussion later on in this conference about issues like that. So what are the remedies for linear thinking? I know none of us are linear thinkers, but there's some people out there in the system who aren't here who are. Actually, let's be frank. All of us are linear thinkers at least part of the time, because that's the way the brain works. We all think, if I do X, I will get Y. The whole of medicine, although it's a complex system, is built on, I need a diagnosis, then I can put some things in place, a plan in place. That's if-then logic. It's relatively linear. Yet every clinician knows, and every administrator knows, and every person on the front lines of care know, what we're dealing with is complexity. So here's some remedies for linear thinking, and I've just put these in the slides, Christina and Doug, just for completeness. Resist the temptation to focus on a problem per se. You'll do that anyway, but also look for interconnections. Then you'll be doing complexity thinking rather than linear thinking. Another one is, consider that you can't actually see very far ahead. People change things in health systems with the intent of improving them and get unforeseen consequences all the time. Because you can't really see that far ahead. I always laugh when I see people doing 10-year plans. You know, that's just too far ahead. It's okay to do that, but then you have to make sure that they're adjustable across time. Another remedy for linear thinking is look for patterns, not just events, in your system. Look for recurring patterns. That's really looking at the culture. Another one is be careful of attributing cause and effect. You know when something good happens in your organization? Everyone seems to have been at the decisive meeting. Not just that, they were actually, if they weren't at the meeting, they were the architect of this or thought about it first, and that's why the meeting endorsed it. Success has many parents, and failure is always an orphan. But just be careful of attributing cause and effect. It's rarely that simple, and it almost never is that simple in complex systems. Another remedy is Generate new ideas beyond your own resources. This is just a plea for saying, inside your head and when you act is not the only way of doing what you're doing. There are many other people with different perspectives. That's a sociological view. Go and sound out your idea with other people. Get a different perspective. Another one is, keep in mind the system doesn't really respond in a one-to-one correspondence between what you do to it and how it responds. In fact, it almost never does. I've got 8 of these, so the last 2. And this is a plea to researchers, really, or people with resources. It's really useful before you do anything to model how it might work. So we use systems dynamics software, but we're a big research group. But it's really useful, even if you've got just whiteboard and some post-it stickers, to model what's going to happen consequentially as a result of your initiatives. And then finally, there's lots of systems tools. People use linear tools often, simplistic checklists. I'm a fan of checklists in the right place, but not to over-checklist, not to have a checklist manifesto everywhere. Just to be slightly provocative. But there's lots of systems tools, sociograms, social network analysis, systems diagrams, and we use a lot of those to describe healthcare in our papers, in our research. So, let's summarize where I'm at now. Command and control only gets you some way and often not very far. So if you've got KPIs, restructuring, policy, prescriptions as your major tools, you will only get so far in a complex adaptive system. In fact, I'm not a fan of that, although I do recognize you need KPIs and a structure and an organization chart and those sort of things. I'm much more a fan of, rather than insisting that people comply with what we want, we have a model that says we want commitment instead of compliance. So I'm in favor of a culture of commitment rather than compliance, is my summary of where I am now in this talk. So, even better is what Chad Dickey said yesterday if you came to the Learning Health System a part of the conference, the pre-conference workshop. He said, you know, we come to conferences and expect healthcare will be frictionless. That's not realistic. It won't be. He was speaking my language. It's a complex adaptive system when he said that. Great wisdom. Chad, are you in the room? He also said, I'm a big fan of nudge. So rather than bashing people over the head with policies or an organization chart, how about we work with people, and maybe if we want to influence or shape their behavior, we nudge them in the direction and then keep the momentum going. So thank you for your wisdom, Chad Dickey. Okay, so far so good. I want to start to finish. In terms of the parabolic curve of this talk, I'm just there. Chair, MC Stephen. So I want to finish. I've been doing some work with countries around the world. And I've published a series of books on international health reform, and Canada is in these books. So the first book looked at health reform, quality and safety in 30 countries. I invited 30 countries to each write a chapter on their national health reforms and their quality and safety activities. The second book, which I'm going to talk about now, asked 60 countries in low, middle income and high income settings, systems like yours and mine, but also in lower and less wealthy and middle income systems. And I asked them each to write one success story on their health system. I did that with a bit of trepidation, by the way, because I wondered, would the low and middle income countries be able to have a really, really far-reaching chapter on what they've done? Because some of them have such little in the way of resources compared to your system and mine, which are wealthy beyond imagination in comparison, even though we think we've got a lack of resources in our health system. So I did that with a great deal of trepidation, and it turned out everybody can write numerous success stories in their health system and share them with the rest of the world. This is really heartening. If we can do it, if they can do it, we can do it. So there was 161 contributing authors from 60 countries, low, middle income and high income countries. These health systems cover 2/3 of the world's population, and the author's tasks were to choose an exemplar from your health system, tell us about it, and give us some recommendations. And this is a summary of what they said. So again, it's deliberate that you can't read this from the floor. You'll get a copy of the slides. So across the world, in the Americas, there was all these things that people chose. For example, in Canada, it was improving stroke outcomes through accreditation standards. But lots of examples around the world. And then in Europe, well, there's lots of countries in Europe, there was lots and lots of ideas about patient partnership with providers. And in Sweden, researching and learning from clinical data because they've got such good registries in Sweden. And so on and so forth across the world. And then in Africa, we only got a few of the countries. I want many more countries when we do our subsequent books in this reform series. And they had things like how we handled Ebola when it came along with the help of WHO. A responsive delivery system in Nigeria. Community-based health insurance in Rwanda when they had gone through terrible things 25 years ago and now have set up really a much better footing and structures and insurance for their health system. Eastern Mediterranean, a whole lot of other ideas about what they did to try and enhance their success in their country. And Southeast Asia and the Western Pacific, including the country we're domiciled in, Stephen, at the moment, including Australia. So if you don't get a chance to travel like I do, and you want to get outside of where BC is, there's a book for you to tell you about health reform and success stories right across the world. Now, these books are very expensive. So I've actually put a summary in International Journal for Quality in Healthcare, just for those who haven't got the resources to buy such an expensive book. Although it looks fantastic, I put it to you, on your bookshelf. And you know, if anybody comes in taking pictures, just make sure it's just behind you, over your left shoulder. It makes you look like you've got about 10 more IQ points. Even though when I come into your office and look at it, there's dust accumulating on the top of it. So what's the summary of this book, and what's the international recipe for success if you're trying to improve a health system or you're part of the health system? Well, there were 9 themes. Improving policy, coverage, and governance. Enhancing the quality of care, what you're in the middle of. Keeping patients safe, the other bit of what BC and this conference does. Regulating standards and accreditation. Accreditation Canada is famous for its programs in trying to have standards and accreditation applied across healthcare. Organising care at the macro level, that's the policymaker's domain. Organising care at the meso and micro level, that's everyone else's domain. Managers all the way through to people on the front lines. Developing and educating workforces and resources, especially for the future. And harnessing technology and IT. We're all doing that because the technology revolution, we think we're halfway through it. We haven't even scratched the surface yet. We've got AI in medicine, genomics, and all sorts of things yet to come. And making collaboratives and partnerships work. So the key messages from this book are, it really takes a positive deviance approach. Mostly when we look at healthcare and health systems, and mostly when you look at what you're trying to do when you're trying to improve things, you're looking at the problems. But actually, everywhere across the world, and lots of places in BC, there are success stories to be told. In other words, we often look at things going wrong and try to fix them. That's what we spend a lot of our quality improvement and patient safety time doing. But there's a case to be put that in your health system, many, many things go right. Yet we don't treat that as remarkable. And we should learn from that. We should have a better system for saying, how can we get so many things right? Rather than the media, for example, saying, here's another stuff up in the BC health system, which I know happens. Any country can provide multiple success stories regardless of wealth, political structure, or resources. And there's lots of stories to be told in BC. And we'll hear some of them in the next couple of days about what constitutes success here. This book is about learning across borders and boundaries, And your work, I put it to you, in a complex adaptive system like the BC Health System, should be learning across boundaries and borders within and outside of your health system. That's your mission. Good luck with it, and thank you for listening.